base. And I'm wondering at this stage if you are aware, if the DHA, I would think, would have to grant approval for that, while it's linked very strongly to the military community. The base commander at a recent event made this announcement, which again is a hopeful piece, and that is that it would be they would perhaps maybe even involved in their own recruitment, but that they would be looking at setting up a clinic, and they would first of all would be for the families of military personnel. Then they would any ex-military families that lost a family doctor in recent times due to retirements. That they would have access to it, and that they would look at a profile of around serving 2,000 patients, which I guess is probably an average for a family physician, or a little bit larger. So I'm wondering if DHA approval has been given for that. Is the province involved in recruitment, or is it going to be the military community that will do the recruitment?
Thank you. The Honourable Minister.
Thank you very much, Mr. Chair, and to the member for Kings West. I'm not really sure if, well, I know that approval from the District Health Authority is not required, but I would probably suggest that there is probably some collaboration going on there, because even with the clinic on base, there would be a relationship with the District Health Authority for minor diagnostics and those kinds of things that cannot be done at the clinic on the base. So I would welcome the opportunity to have that kind of relationship, continue to expand. You know what? We've seen over the last year a much better appreciation and better openness from our armed forces to look at the communities that they're in and the communities that they serve and the provinces that they're in. Just recently we talked about the opportunity to use the Stadacona Hospital to do some minor procedures, where we had a great opportunity there. And I again thank the Rear Admiral for his foresight on this one to let us try that, and look forward to an agreement where more Nova Scotians can actually use the facilities. Mr. Chair, regardless if it's a D&D hospital or if it's a provincial hospital, really doesn't matter, because at the end of the day, the taxpayer is the same. The dollars come from the same place. It is all our infrastructure anyway. So there's got to be better ways to do things. And really the crunch in doctors and services and those kinds of things, really make us look in different ways. So, if there's something that I can do to help that clinic along and for that area, I would be more than welcome to visit with the member opposite and see what kind of helping hand that we could give to open up a primary care clinic like that.
Thank you. The Honourable Member for Gippsland.
I appreciate that response and offer of support as it moves forward. On the nursing retention area, I'm wondering if could have I guess a little bit of an overview of any statistics that have been gathered in terms of when a nurse graduates from DAL or St. FX or CBU, and they come to one of our hospitals in the province. Do we have a picture of how long they'll remain in that first posting? Because I know that one of the I guess suggestions, or one of the areas that have been brought to my attention, is that Valley Regional seems to have a turnover of 20 nurses or so each spring, and I'm just wondering if there's something more that the province can be doing in terms of retention of nurses. And at this point, I haven't spoken with the nurses union on this particular issue, but young graduates, and especially those that are recruited from out of province, it's like they try on the hospital, they try on the community, and again, you know, having to recruit on an annual basis fairly heavily to fill the required positions, and we know, you know, that the daily demands in our regional hospitals are pretty extensive. We've heard from the South Shore recently that they're running into a real crunch around having sufficient nurses. So I'm just wondering, is there anything being developed or is in place to try to retain nurses that we do recruit from our province or interprovincially?
Thank you. The Honourable, the Minister of Health.
Thank you very much, Mr. Chair. And Mr. Chair, you know, speaking quickly to the issue of basically trying on a hospital, you know, the member opposite is quite right. What happens a lot of the time, especially from individuals who come from outside, in this specific case, nurses, you know, I think they come to Valley Regional, for instance, because of its rural nature. But I think they quickly find out that it's probably our third most complex hospital in the province. You know, it is a very busy hospital. They are seeing some very sick people. They are providing some very complex health care. And, you know, if that's not what you thought it was, then people tend to go to somewhere that they can find maybe a slower pace or what have you. So, I mean, that's the challenge that we have from getting people from outside or from a different area to come work in a facility like that. What we're also seeing, though, especially the experience in Kentville at the Valley Regional, is that those nurses that had time to train there, you know, that have done their clinical experience at that hospital, stay at that hospital, you know, so we need to do more of that. And I think by the expansion of the seats for the nursing program, that, you know, we'll have a better opportunity to have that co-op experience happen, you know, and get them to all hospitals, you know. And I think, you know, at that point, when they're still students, that, you know, you can start putting your fingers into it and trying to grab them and try to get them to stay in those kinds of facilities. To speak to more specific, you know, the nurses settlement, the current nurses union settlement, have a number of initiatives in it for the recruitment and retention of nurses. You know, just to talk about, you know, some of the retention, long service increments. After 25 years of service, they get another extra 3.5%. Retention of potential retirees, a 2% bonus payment for the fulfillment of a 12-month commitment after retirement eligibility. Retired nurses incentive, nursing leadership in our practice practicums, up to $600 premium for each program. An 80-20 trial that the NSNU is doing. Sort of changing that temporary, regular, full-time positions of 80% clinical practice and 20% mentoring. Innovative shifts, so we are trying to look at that shift composition to see if there's a better way to staff the floors. And there's like cost sharing of health benefits for retired nurses, voluntary reduction of appointment status from full-time to part-time, re-entry of retired nurses, creation of preceptor pools for mentoring, job sharing, and these are things that, you know, we really didn't necessarily have in our hospitals for our nurses. So, you know, I think there was a lot of thought and a lot of work that went in on behalf of the nurses union and was accepted by government during this last round. So I want to thank the nurses union for their dedication, for their membership in getting some of these things that are very important to all Nova Scotians.
Thank you. The honourable member from Kings West.
Thank you very much, and that gives an overview of some of the areas that are hopefully will be implemented and will perhaps retain nurses longer that come to the Valley Regional and perhaps any of our hospitals across Nova Scotia. Before I forget this thought, because during estimates, I had brought this particular issue to estimates and also here through question period and through press releases, as the minister well knows, along with my colleague from Annapolis, and that was the issue of the emergency ward in Middleton. and I'm very, very pleased to say how well that issue has been addressed. And it was a very, very difficult one for us because because lots of times people were had to find out by way of the radio because some occurred within a relatively short period of time without a long advance notice. So I don't know whether it's a model that can be used in other hospitals, but the assignment of a doctor who has been going through training, as an emergency room doctor, has some in his background, but is continuing to upgrade, but responsible for the scheduling, the filling in, and I'm just wondering, was this, a little bit by design, or it just so happened in terms of a doctor in the area in relation to the military, or whether or not it's something that you've looked at where in our small or rural hospitals where the emergency ward, again, without a lot of family doctors, remains a very, very busy place and a very, very high rate of service on a daily basis. So I wanted to acknowledge that. If the minister wanted to make any comment to that, fine, but I just wanted to acknowledge that the service has substantially improved. And I know I had to write the CEO in the area and the hospital board about a couple of cases that were very disconcerting when patients arrived at Soldiers Memorial Hospital, and of course the emergency room was closed. And if you've come from the east to the west and then had to go back to Kentville, you've lost a lot of time. And we had a couple of difficult cases outside of an ambulance transport. So I just wanted to say that that's part of a good news story. And I don't know if it's a model that you are actually looking at, or was it more by circumstance that it happened?
Thank you. The Honourable the Minister of Health.
Thank you very much, and it's good to hear of successes in emergency care in this province. And I think in Middleton there was an appreciation for trying in a different model. What I've said in the past, there's no cookie cutter solution for any of these emergency rooms and trying to keep them open. And I think what happened there is that there was an appreciation from the community, appreciation for the DHA to sort of open it up a little bit. And and I think that we need to look at the successes of places like Middleton, but at the same time that I don't know if that kind of solution would work in a place like Digby. I don't think it would. So we need to find that true solution for Digby. Anyway, it's good to hear that worked, and I think there's probably a little bit of luck involved into it, but I think it also has to do with the perseverance of the community, of its MLAs, of its district health authority to make a solution work.
Thank you. The honourable member for Kings West.
Thank you, Mr. Chair, and thank you, Minister. One of the areas, of course, that remains a troublesome one, not only in this area but across the province, is the long-term bed conundrum. And we know that in relation to that this year, Code Purple was in order at Valley Regional for several weeks in succession, and we're reaching now perhaps even a point, at the manor, in the Berwick Manor, which is again an outstanding facility, that is going to be looking at some renewal. In our area, there is 50 long-term care beds planned for Middleton, but we may actually see then the closure of one of the current facilities in Annapolis. So therefore, there may be no net gain, for beds. And I know that the department has been doing some inventory of the Valley region, And as I've mentioned on a couple of occasions in this House, you know, the demographic in our area, we're in I guess, an advanced area of what's going to happen to a similar degree across the province when we have the number of communities that have a high percentage of 65 plus, and we know that demographic is in fact accelerating its impact on the healthcare and the need for long-term care beds. So as a going forward to try and deal with that need, and also one of the elements in reducing the number of beds at Valley Regional that are occupied by those waiting long-term care placement, can we see some possible alleviating of that critical situation in our area?
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair. And Mr. Chair, you know, as the member opposite alludes to, and I think he's quite right in his assumption that this first round of 840 beds really revolves around equalization. You know, making sure that all districts and all areas of the province are represented with long-term care facilities or beds equally. You know, if we look at the deficiencies that we had in Colchester, East Hants, was phenomenal. I mean, there was really no long-term care facilities in that area, you know, and that was sort of repeated here and there across the province. So even though the Valley itself did not necessarily have a big introduction of beds, I mean, Kentville did get a 62-bed facility, so that will, you know, sort of spill over into the different areas of the Valley. But at the same time, you know, different areas will be looked at during the second round, which will be sort of increasing that number to make sure that we have the available beds for 10% of population over the age of 75. That's sort of the overarching ratio that we've been trying to adhere to across the province. Just for a little more specific to the member, currently the Annapolis Valley District Health Authority, there were 58 people as of March 7th waiting in hospital for long-term care placement. In September of 07, there were 88 people sitting and waiting. And as of March 5th this year, there were 72. So we have been able to drop that number down, and we hope to continue to drop that down even further. And the other issue, of course, for it is the beds, the actual acute care beds in Kentville. Apparently, as far as I understand, 14 of those 21 new beds that they are constructing, 21 of those beds, or 14 of those 21 beds are in service today. We'll look at those extra 7 beds will come online, I believe, in September. So again, there's some real incremental changes that will continue to happen. So code purples and really being too tight will stop happening in places like Valley. Oh, that's mine.
Thank you. The Honourable Member for Kings West.
Thank you, Mr. Chair. And obviously related to this whole issue is home care, and it's one of the pieces that again I've talked about during estimates and here in the House on a number of occasions. I'm you know, pleased to say that again we've had some improvement in our area, and I don't mind going on the record to say that the new I guess supervisor or CEO in our area, John Dow, has done a very credible job with trying to improve home care on a number of fronts, and in particular making schedules work a lot smoother. However, one of the areas that has been talked about at our board and MLA meetings, and when we have all the MLAs from the Valley get together with the CEO, they seem to be comfortable with the idea of devolution to the DHA, and I'm wondering if the Department of Health, is looking at preparing or agreeing to at least, pilot one of the areas that has been very troublesome, for, I think, for the delivery of home care in the province. Kings County has had many challenges. There have been recent improvements, and I'm pleased to say that, because the beneficiaries are the seniors who are getting more timely care. It's an issue that I would prefer that I didn't have to bring to the House and bring to the Minister and Janet Knox in our area. But I'm wondering if there's still some thinking, and if that's a logistical change that the department is still considering.
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair. And Mr. Chair, I'm very happy to tell the member opposite that we will be devolving home care services, long-term care services to the districts as soon as we can. That has been an announcement that we made when we talked about the recommendations of the facilities review of the transformation document. So that is ongoing. There's been there's a team that's been set up to help that transition happen. Of course, there is some ongoing discussions right now, of course, with the unions that those individuals sit in, and how that transfer is going to happen, and how those benefits are going to transfer, and all those questions. So that's something that will be ongoing, which I think, from the discussions that I have with my district, and I'm sure you've had with your district, to talk about that continuity of care through these systems would be much better managed if everybody sat in the same room, rather than one DHA, one Department of Health, somebody doesn't work on the weekend. Anyway, it's just it was a bit of a mess. And I think if we can make things a little more efficient, a little more understanding, I think we'll go a long ways. Another thing that I think is going to benefit seniors and their weights and being able to keep them longer at home is the addition of 400 daycare seats, basically 400 adult daycare seats that, if you are taking on the task of taking care of mom or dad or an aunt or what have you, that you'll be able to bring them to a daycare, to one of these adult daycare centers. They'll be able to get the recreation and the type of engagement that seniors would need in order to keep them healthy, and being able to give the caregiver some time to do other things rather than spend all that time with their parents or loved ones. So that's a big issue that's going to be very well received in the communities. And there's 400 for the province, and I forget what exactly the breakdown would be for Valley, but I know Valley has a proposal before us for this as well. I can say that we've been making some steady improvements in home care wait lists in this province. There are two really bad ones. Valley, I think, would probably be the worst one for time to get service. The biggest number, of course, is here in Capital, but that's, I think, a function of the population base. But just to give you an example, waiting for home care services in the Valley was 180 as of February 2007. In October 2007, that number had been brought down to 164. And number of clients waiting today, or as of March 2008, is 116. And there's partial service being delivered to 89 of these waitlisted clients in the district. So there is some steady improvements being made. The best example that I have is really in the Colchester East Hants area, where they had a wait list of 68. It went up in October 2007 to 88, and today they have no wait list. So, I think it can be done, is to get the professionals trained up, get them working, get them out in those communities, and provide home care services to our seniors. And that is, I think, way better than the services of a long-term care facility. There are people that, they don't need to be in a long-term care facility. they would rather be at home, and we need to have and continue to expand on those kinds of services, and and hopefully we can make those steady increases or decreases in wait time for the residents of the valley.
Thank you. The honourable member for Kings West.
Perhaps, Mr. Chair, if you could inform me as to the time remaining.
The member's time will expire at 12:33.
Thank you. One of the areas recently brought to my attention was that of mental health delivery at the community level, and it was brought to my attention by a Department of Justice worker, obviously a case worker, who would have clients that are in need of mental health counseling, mental health professionals, and the issue that was brought to my attention was that many of the providers in the community level of mental health are also in private practice. So they're in private practice. They also serve in the public domain as well, and they are finding that having a client who needs some help that's going through the public service is in fact people that were that in October, November, that wanted to get those services have not yet been supported and have not had their cases brought forward, but knowing that people who were getting through the private delivery were much much quicker. And I'm just wondering if this is an area that is problematic across the province, and what kinds of ways in which this is going to be addressed by the Department of Health.
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair. And there are two things that we're trying to do when it comes to this issue. Of course, it's the increase that we're seeing this year of $2.8 million for mental health services, which will increase the services for the ACT program. The ACT program, I believe, is the one down at the train station that is seeing, of course, youth at risk. The other component of that $2.8 million will be going directly to the community mental health clinics, which I think will mostly go for staffing so that we can actually see the individuals as they need help. The other piece that we're investing in, of course, is in the addictions round, is we are adding dollars to the addictions programs across the province. And I forget exactly the dollars attached to that. There's $26 million that are going to that, which is an increase of about $3 million. So they are small steps still, but I think they're steps in the right direction.
Thank you. The honourable member from Kings West.
Thank you very much, Mr. Speaker. And just a couple of other areas to touch on as my time is winding down here. One of the issues that I brought to the House here was the question relating to breast reduction surgery, and I know that the department has made some changes in the criteria. However, it continues to be an issue for women across the province. I don't like to bring individual cases here, but again, I've had a couple of others recently come to my office with this. One of the related issues, and I know that currently there are still studies that are going on, research around this area, but again, the linkage of body tissue, the amount of breast tissue mass, and its relationship to cancers is now being well established. And across the country, we have lower criteria in place in eight other provinces one other is similar to Nova Scotia, and there is one province that do not place criteria on getting breast reduction surgery. I'm wondering, how often are the criteria reviewed? Also, in the most recent case that I've approached the Deputy Minister with, her doctor had appealed twice for breast reduction surgery, and my awareness of her need is extreme. And I'm just wondering, now with the health linkages, is there room for, again, an appeal to a body that can give perhaps more objective analysis as to the need that may arise?
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair. And maybe I'll talk a little bit about mental health and addictions just to finish off that train of thought, and then we'll talk about breast reduction afterwards. Just for basically the members' interest, DHA 3, which of course is Annapolis Valley, will be getting an increase in mental health of about 5.9%, which is another $365,000 to their budget. So there's going to be some, I would say, some significant improvements in mental health services for the Valley. The other piece, there's outpatient clinic expansions for CDHA and IWK, which will have impact for residents around the province, of about $550,000 to address those community wait lists that we're having today. The issue of breast reductions is one that is difficult because there is such a varying listing of the reasons why or why not to fund or not fund. If you look across the country, the specifics are all different. If you could say that it was just an issue of grams, so the removal of X amount of grams constitutes funding, and less than that it does not, or if it has to do with back pain, shoulder pain, et cetera, I think it's a very difficult one. I know when we reviewed it from your discussion, your urging, we were able to drop the requirement from 500 grams to 400 grams, yet it still left a lot of the other pieces in place. Quite honestly, we could take restrictions completely off. And really all it would end up doing would just make the wait list longer, because we only have a certain amount of surgeons that can offer this type of surgery. So it's, do we or do we not do it? I don't think there'd be a huge cost impact, but I know that individuals who are waiting for breast surgery today do wait an awful long time. I don't know exactly what that wait list is, but some people that I've talked to, they wait up to 4 years to get through that whole system to finally get their breast reduced. So I think we'll continue to review it as it goes along, but there's such a discrepancy amongst provinces on what's funded and what's not funded that it's a difficult one to really grasp.
Thank you. The honourable member for Kings West.
I think I'm just down to a matter of seconds. So rather than getting to a question today, I'll wait till the next opportunity. And I wish to thank the Minister, the Deputy, and the staff for being here today. Thank you.
Thank you. The Chair now recognizes the honourable member for Halifax and Edinburgh.
Thank you. Thank you very much, Mr. Chair, and welcome to the Deputy Minister and the staff from the Department of Health. I'm pleased to have an opportunity to raise a few issues with you. This is always a great opportunity to talk in greater detail about concerns that are on the minds of the people of Nova Scotia, and healthcare is always top of mind. I think we would all agree on that, no matter what disagreements we might have about other aspects of healthcare provision, that it's the most important area for most people. In the news in the last little while, we've all, I think, observed with a fair amount of shock and concern the situation in Newfoundland, the public inquiry that is occurring there with respect to the accuracy of diagnostic testing. And it's not peculiar to Newfoundland that these problems are occurring. The question of the accuracy of pathologist testing is now a topic in several other provinces as well. And I want to ask the minister if there have been any concerns here with the accuracy of our testing in the province of Nova Scotia in any of the DHAs or the IWK. And I also want to ask what quality assurance controls are in place to assure that we are getting the most accurate diagnostic services, and also what protocols does the Department of Health have in place that if there are inaccuracies identified, that patients will be informed of this in a timely manner and that the public will have that information.
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair. I welcome the member for Halifax Needham to of course, the estimates on Department of Health, and I look forward to the next hour or so of discussion of healthcare in this province, and more specifically to the HRM. And I know that you'll probably be talking about some mental health issues and, of course, some clinic issues that do affect her riding. When it comes to pathology in this province, after the nightmare, I guess you could call it, in Newfoundland, we did ask a number of questions about our pathology program here in the province, and we have been assured by the College of Physicians and Surgeons. We've been assured by our pathologists, which we do have a larger group of professionals, very well-trained professionals who do work collaboratively, that the impacts of Newfoundland, we would not see them here because of the way they practice. They do practice. I think really the reason is in Newfoundland, they really worked alone. There was no quality control put on their work. Here in the province, again, they work collaboratively. They do check each other's work and do those kinds of things. So I'm very comfortable in saying that our program is probably one of the better ones in the country, and we will not be seeing the kind of incident that happened in Newfoundland.
Thank you. The Honourable Member from Halifax Needham.
Thank you, and that certainly, I think, is an important reassurance for all of us. And I remember, I think it's quite a few years ago now, Mr. Chair, there was, and it was a very different issue, there was an individual at the IWK who got into a bit of trouble, and I think it was identified after he had left the country. But nevertheless, I think it is very important that we have these reassurances. I want to turn my attention to another matter that I'm sure the minister and his staff are aware of, and I'd like to explore what, if anything, the department will be doing with respect to this situation. On the 19th of March, and I will table this, on the 19th of March, a cardiology resident at the Queen Elizabeth Hospital wrote an opinion piece in the Chronicle Herald with respect to the concerns that he and his colleagues had around the fast food, the serving of fast food in the facility at the Queen Elizabeth Hospital. And as the minister would be aware, young people from Citadel High were leaving the high school and coming over to the hospital to get fries and Timbits and what have you. And he and his colleagues had staged a bit of a demonstration the end of February. They had left the hospital and gone to the cafeteria over at the high school to get a healthy lunch. And he and his colleagues, and since he wrote the op-ed piece, his name, by the way, is Dr. Rob Stevenson, and his colleagues, 2 nurses, have written letters to the editor, Jillian Yates, a nurse practitioner, and Jacqueline Humphrey, a dietitian, encouraging the Capital Health Authority and the hospital to practice what they preach, to deal with this issue, to have more healthy food in their facility. And you know, it's interesting that they brought this forward. It's an issue that certainly other people have raised as we've seen a more commercialized element in our hospitals, and the pressure on these facilities really that has been generated by government itself to get DHAs into the business of cost recovery, looking for alternate funding arrangements, looking for ways to generate revenue. And one of the ways that our healthcare facilities have looked to generate revenue has been charging fees for parking in the parking lots. And they have eliminated quite a few of the cafeteria services that they had in the past, and they've replaced them with franchises, you know, Tim Hortons, Robin's Donuts, or what have you. So the end result is that you have these cost centers now in our hospitals, but the dietary choices at these cost centers are really in quite strong contradiction to what most of the medical professions who are trying to deal with disease and illness have to cope with. So given that there is this contradiction, that these young medical professionals have made it so visible, what is the Department of Health intending to do to address that issue? And hopefully it's not more study. I don't think this is something that really needs to be studied.
The Minister of Health.
No, if I had to say study one more time, I tell you. This is an issue that, even though I've been to the hospitals and I've actually gone and grabbed a pizza, you know, when you really think about it, you don't think of the overarching issue. And when we built the new high school, I don't think we realized that students would probably hop on over and go serve themselves the unhealthier foods there. So we do need to address that. And what we've done is through the committee of CEOs is bring in an HPP, of course, the individual that's responsible for healthy eating, to have some discussions with the district health authorities so that they do make better health food choices. I think in respect to the Capital District Health Authority, I believe they've got a number of contracts that they need to get out of in order to get them off-site. And I know that they're looking seriously at getting rid of those unhealthy foods so that we can offer the more healthy pieces from their cafeterias. So there is work going on right now, and I will report back to the member and to this House when that change has happened.
Thank you. The honourable member for Halifax Needham.
Thank you. Does the minister have any idea how long it will take to get out of any of these contracts? And are we looking at this occurring in the IWK as well as at the Capital District? And will it apply to DHAs perhaps in other parts of the province that have similar arrangements?
Thank you. The Honourable Minister of Health.
Thank you very much. No, this discussion happened with all CEOs of all districts. More specifically, I don't know the specific contracts that the District Health Authority would have with these service providers or these food suppliers. Though I know there probably would be some kind of demonstration that would happen on behalf of Tim Hortons drinkers if we ever pulled the Tim Hortons out of there So there has to be some kind of discussion around there. I know I was there the other day, and I think I drank 2 coffees from Tim Hortons. So, we need to find a balance there too. But I think if we have in the food court type setting those healthy choices there, and only the healthy choices, I think we would go a long ways in helping the families and the individuals that are in those hospitals.
Thank you. The member for Halifax Needham.
Thank you very much. Thank you, Mr. Chair. I certainly, being a Tim Hortons connoisseur at times myself, would hate to see Tim Hortons entirely disappear, but absolutely, I think you do need those choices. I want to ask a few questions around the issue of wait times and information about wait times. I note that in February of this year, the province received additional money for 2 pilot projects in Nova Scotia with respect to patient wait times guarantees. And I know that one is with respect to building a strong province-wide information network with respect to orthopedic surgical services. Now, I want to ask questions about this particular pilot project and the stage at which it's operational right now. And I want to offer to the minister and staff several experiences that I've had in my constituency office where individuals have contacted me as their MLA because they have a family member in a great deal of pain, lengthy waits, and they're beside themselves. And they're looking for advocacy, or they're looking for advice from me as their MLA. And, it is difficult in terms of, we're all very clear that queue jumping, for example, is not an acceptable practice or part of our system. Yet we want to offer people who feel quite desperate by the time they get to my office, if they're looking for help with their medical situation, they're desperate. That's how I look at it. So I want to offer some good information about how they may advance their own health care. And so I tend to say, well, perhaps your surgeon is a surgeon that has an extraordinarily large clientele, and there may be a surgeon somewhere else in the province who has not as great a wait list, yet there's no possible way that I or any layperson can get access to that information. And you end up having, I've had constituents, they've had to go back to their family doctor. Their family doctor has to attempt to do the research and find out, make referrals, and it's an extraordinarily cumbersome process. The information isn't there, and I think that for people who persevere, and by luck or by contact and good connections, they're able to, if they have a family doctor who's really well connected, he was in med school or she was in med school with somebody else who's, married to an orthopedic surgeon in New Glasgow, then they can maybe get them in quicker. And this is not right. I mean, it's just not acceptable that people aren't able to find out what the wait times are, what they're for the different groups or different surgeons in different parts of the province, and they can ask, go to a website, get the information, ask for a referral, and be referred. And so I'm wondering, is this what is anticipated? what exactly is this pilot project going to do to facilitate the fair access to information for people who are attempting to improve their own healthcare situation as they wait for unacceptably long periods of time on lists quite often here in the Capital District?
Thank you. The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And if I just may take a second to do a quick introduction to a couple of people who are in our
Please
gallery.
do.
I want to welcome Leslie Porter. Leslie Porter is, of course, the much better half of our member from Hants West. So I want to say hi to her. And I also want to welcome my better half, Anne, who's up in the East Gallery as well. So going to my answer, wait times is it's a complex issue because the system is designed in such a way to be complex. There are so many practitioners, so many diagnostics, and it's very difficult to navigate through that melee of services. What the $8 million that we received from the federal government, and I thank the Honourable Tony Clement for his input and his help along the way on this one. We have two pilot projects, or two basic projects that are in that $8 million. And in that $8 million is the diagnostic imaging project, which will help family physicians order tests. And that program, which has been designed by radiologists and actually by the Canadian Radiological Society, will look at the specific test, the specific ailment, and actually suggest the kind of test that the patient might need. And by correctly identifying the type of test that person might need, it will stop, just basically blanketing all of the tests, and they're cutting down costs and cutting down and speeding up the service for patients. So that's the first $4 million. The second $4 million is basically the development of an orthopedic portal. And the orthopedic portal really has to come after the assessment clinic. So let me step it through a little bit here. Is through a partnership with Bone and Joint Canada, and basically looking at a project from Calgary. There's basically an assessment clinic that is being created here, that physicians will end up referring a person requiring orthopedic surgery or some kind of orthopedic question. They might not need surgery after assessment. Send that person to that clinic. They will be assessed by maybe an orthopedic specialist, maybe a nurse, maybe a physiotherapist, and then they can identify the correct type of treatment that this patient might need. The examples that we're hearing from the Calgary experience is that that's almost knocked down the wait list. Well, I don't know if knocked down the wait list, but the request for surgeries by about half, because it's speeding it up. I mean, right now, if you're waiting 2 years and maybe all you needed was a knee scope in the start, you need the full knee replacement by the time the 2 years hits around. So, if we can do this more speedily, we can get the more appropriate service for them. So, by investing in that wait time or within that orthopedic assessment clinic, I think that will make a big difference for the patients, because that's something you can understand. You can understand that you're being referred to the clinic, and the clinic will give you those directives and treatments for the next step. And right now, the family physician is basically referring you off into the gray area, and you have to wait until you get that phone call someday by the specialist, and that's not acceptable. Also, just a note from my deputy here is that clinic is for pre and post. So after your knee replacement, after your knee scope, after physiotherapy, that you continue to contact and work with that clinic on your joint problems that you might be having. Anyway, so after that step, once you get referred on, then you would be able to sign on to the orthopedic portal that would give you up-to-date information on where you are in the wait. Okay? And that way, you know that you can start planning that, all right, my wait's 8 months, and then you know where it's going. And depending on emergency surgeries, whatever it may be, it could get a little longer, it could get a little shorter, but at least you'd have an idea. Right now, there's no appreciation for that right now. It's all of a sudden you get a call out of the blue and your schedule's booked for 3 weeks down the road or something like that. And, you know, that's not fair because you can't plan for that, because if you get a knee replaced or get a hip replaced, you know, it's a number of weeks of physiotherapy and getting training and getting ready to go back into your community. And I know my deputy's had that opportunity twice now. I think 2 hips. Yeah, so it's you know, it's quite an operation and quite a recuperation that goes in it. The other thing that we're doing for wait times is we're putting in each district wait time coordinators, a person that can help patients navigate through this maze of services, and hopefully, you know, they won't be coming to our MLA offices and saying, "Oh, I don't know where I am," and then we have to sort of call through 10 people to try to figure out where the heck they are. These wait time coordinators will have that information available to them. So there's basically 3 initiatives going there on orthopedics alone.
Thank you. The honourable member from Halifax Needham.
Thank you, and that's very helpful. How will patients get to a navigator? Like, what is the referral process for that?
Thank you. The Honourable the Minister of Health.
Yeah, you can once we get them deployed to all the districts, we'll advertise the availability of these coordinators, and then you as public can contact these wait time coordinators and they can work with your file. So it would not require the referral of your doctor to a wait time coordinator. Those wait time coordinators are there for all people within our system.
Thank you. The honourable member from Halifax Needham.
Thank you very much. That's very helpful. It's interesting that you give the example of people needing some time to prepare. I had an individual in my constituency that I wanted to use as an example, not specifically to get any intervention for him because it's now long past what's required. But it was a very good example, I think, of where we have a need to do something. I'm not entirely sure what, but this individual is a person with a disability, and he's in a wheelchair and has been for quite a long time. And he still has upper body strength, and he moves himself in and out of his chair mostly with his arms, and he's developed carpal tunnel syndrome quite badly in his wrists. And he was, for some time now, quite a long time, waiting on wait lists, waiting for surgery on his wrists, and he was contacted on a Thursday and told that his surgery was going to occur the following Tuesday as day surgery, and he was very happy about that. But then he ran up against 2 problems. Number one, of course, as a person with a disability, he needs to get transportation through Accessibus, and they need a 2-week period to schedule an appointment. And the more difficult problem was he would require home care after he came home, because he would, after having the surgery, wouldn't be able to get himself in and out of the bathroom, prepare for bed, any of these kinds of things that he normally would be able to do. And because there was no home care arranged, and home care isn't arranged in advance of going into hospital, and my office were informed that there was probably a minimum wait of 2 months to get him home care. He had to cancel a surgery that he had waited like 14 or 16 months for and start all over again, and with no assurance that anything would change. And our office, my office, when he contacted our office, we knew the Accessibus problem was going to be there, and I said, look, we will make funds available for you to get a private taxi. There is a service for people with disabilities here in the city, but around home care, there wasn't a thing that we could do. And we spoke with his family doctor, who said it's not their responsibility to make these arrangements. And we spoke with the Capital District Health Authority, and they told us that they can't do these things either. So it was very frustrating, and he hasn't had his surgery. He's on a list, and it may be a bit of a unique situation in that he is a person with a disability, but nevertheless, it just seems to me to be unacceptable that somebody would find themselves in this situation. So would this be a navigator kind of situation?
Thank you. The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And Mr. Chair, yeah, I think some of that could be helped out with the addition of a wait time coordinator to try to coordinate these other services that need to be available for a patient. But it also really underlines the issue of transformation in primary health care. Everybody should know what's going on. The person scheduling the surgery should have known that this individual needed home care. So knowing full well that home care is not available in 4 days, they should have been able to work out their list and made it more appropriate for this patient. So that's why we need to change. And even to a physician who says, well, that's really not my responsibility. Well, it's everybody's responsibility, because we need to be there for the patient. So I think the wait time coordinator will be a big addition and a good help to the system. But ultimately, we need to transform, and that's why devolution of home care, I think, is important, so that the schedulers for surgeries know in advance what the home care wait is going to be and try to put them together. And I think that would make a huge difference in helping out patients like yours.
Thank you. The honourable member from Halifax, Needham.
Thank you very much, Mr. Chair. And that brings me to my next point, my next question, which is about scheduling of home care. I think if there's one complaint that we hear as MLAs with respect to home care beyond the long waits for home care, it's how it's scheduled and the unpredictability of scheduling, I guess. It's frequent for some recipients of home care services that they see quite significant changes in any kind of routine scheduling, so that some days they may get a home care worker. Generally, I'm talking about nursing home care, coming in the morning, but sometimes in the afternoons, sometimes not until late in the evenings. And I'm wondering what arrangements the department has with the various home care providers, the VON and what have you, to support them with technology and training with respect to scheduling and then quality control over the actual services that are provided.
Thank you. The Honourable the Minister of Health.
Thank you very much, Mr. Chair. And this is one that we've been dealing with for a number of months now. In specific, really building around the home care services of Northwood Home Care Services. And not so long ago, we were in the contract negotiations with the workers for home care. And do you want to do anything? Okay. Basically, the Northwood contract, we had an issue around guaranteed hours for the workers, because this is a service that's very difficult, because you have a group of employees, the service providers, who really doesn't match the number of need. We're trying to spread these individuals out across a city and across a number of different patients. And we need to try to have the best system that we can put in place. But the Northwood contract, I think, has taken some appreciation for this, to try to be consistent with patients, to try to, if you're going to be 9 o'clock, show up at 9 o'clock, and try to be at 9 o'clock every time, rather than giving the call and maybe being there. So some of our service providers, though, don't have any necessarily policies that that help the patient out this way. You know, it's a service, and we show up when we show up, and that's not acceptable. We need to make changes to that, and I think there's an appreciation now that these policies are being developed.
Thank you. I understand there's an introduction. The chair now recognizes the honourable member from Dartmouth South, Portland Valley on an introduction.
Thank you, Mr. Chair. On behalf of my colleague, the MLA for Dartmouth North, I'm very pleased to welcome the law class from Dartmouth Senior High School and their teacher, John Nemo, and I would ask fellow colleagues in the Committee of the Whole, Committee of Supply, to give them a warm welcome. So yes, please rise.
Thank you. The honourable member for Halifax Needham.
Thank you very much, Mr. Chair, and welcome to our guests in the gallery. Well, that's really reassuring. I think that for people who rely on these services, they too sometimes have other things going on in their lives, other appointments and things, and so the scheduling and having some predictability around scheduling is very, very important, especially when these services are delivered in somebody's home, because there is an element of privacy and what have you there, and people, we all sort of view our homes as our domain, where we're the top dog, and it's hard to have people just popping in and out at will sometimes, even if they're providing us a service that we really need and we appreciate. So I know many people in my constituency appreciate their home care services and providers, but they are wanting to have some regularity in the scheduling, and I know they would. They very much appreciate when they have the same care provider over a period of time too, because that person gets to know their condition and their needs, and like a family physician who has known you for a period of time, you develop some trust in their ability to care for you and their knowledge of your condition and your needs. I know my time is about at an end here. I wanted to take an opportunity to thank the department. I'm assuming the department has provided funds for the recent campaign around transplantation and the need for Nova Scotians to sign their organ donation cards. And there are several hundred individuals in this province waiting for various kinds of transplants. And it's very important that we continue to encourage people to be organ donors. And there's no greater gift than the gift of life in many respects. So I did want to thank the Department of Health. It's been a concern of mine that resources hadn't been allocated maybe in this way for some time, and I'd like to see that continue, Mr. Chair.
Thank you. The time allotted for debate in Committee on Supply has now expired. The chair now recognizes the Honourable, the Deputy Government House Leader.
Thank you, Mr. Chair, and would ask the clerk to report any progress.
Is it agreed? Great. Carried. The Honourable, the Government House Leader.
Try again. Thank you, Mr. Chair, and that concludes the government's business for today. I would move that we now adjourn until Monday, where the hours will be from 3 p.m. till 10 p.m. Following the daily routine, we'll go into committee, the whole House and Supply. Time permitting, the government business that will be called will be private members' bills for second reading. Numbers 3, number 81, number 129. Time permitting, following that, public bills for second reading. The following numbers: 120, 126, 127, 130, 131, 133, 135, 138, 144, and 146.
Thank you. The motion before the House is for the House to rise and meet again on Monday between the hours of 3 p.m. and 10 p.m. Is the House ready for the question? Question has been called. All those in favour of the motion, please say aye. Contrary-minded, nay. Motion carried. The House stands adjourned until 3 p.m. on Monday afternoon.